Okay, well, welcome. Today in Small Talk, Big Issues, we have the great pleasure of having a conversation with John Pate. John is professor of internal medicine and global public health at the University of Michigan. He's also a senior research scientist at the United States Veterans Administration. He's also an adjunct professor in universities around the world, notably in Latin America. He has degrees from some of the best universities on the planet and helps others to get similar degrees and is really one of the foremost specialists, it's our pleasure to know, in questions of patient support and patient behavior. So welcome, John.
Thank you very much, Kevin. It's a real pleasure to be with you.
So as usual, the format here is I'm going to ask you 3 questions about modern transformative patient support programs that are really designed to help patients adopt favorable health behavior. And one of your many specialties, and one of the things dear to your heart, I know, is use of digital technology in patient support. So the first question I'd like to ask you, what are the advantages of digital programs with respect to more traditional kind of, let's put some nurses on the phone and support patients? What are the advantages of a digital approach?
I mean, there's so many, Kevin. It's hard for me to really limit to some of the top advantages. We're living in such an exciting time because people all over the world now have a device in their pocket that they can be in continual communication with their healthcare team. That's the first time in the history of our planet that we've had that. That's important for a couple of reasons. First, in the best of circumstances, people with chronic disease, they just need a lot of help. They often might need daily assistance, they might need reminders, assistance with making behavior changes. And even in the best healthcare systems where people have the best access to care, it's really unlikely that they're going to have that level of support. But what we know is that most people in the world don't live in places where they have that great access to care. So for the first time, people that have geographic barriers to access, economic barriers to access, other responsibilities that make it impossible for them to come in to see a doctor or a nurse face-to-face, or even to receive a phone call during normal business hours. Now we can be in communication with those people. So those things make mobile health, the field of mobile health, really, truly exciting.
I find it interesting, given what you're saying. You do a lot of work, of course, in the United States, but also in Latin America. And even in developing nations, you see that same kind of digital access kind of helping to reach out to other populations that have been poorly served. Do you experience that regularly?
That's absolutely true, Kevin, that people all over the world are now connected. Some of the major international statistics show that there literally are more cell phones in existence, in functioning in the world, than there are people in the world right now, because some people have more than one phone for business reasons, right? But there's literally almost no people in the world that don't have access. There are exceptions, and those exceptions are really, really important. But in most countries, most people can be in communication to get self-management assistance by their phone. In many places, of course, now with COVID, or in places that have other challenges, like they're very violent, it's difficult to be out in the street, people don't want to be out in public places for all kinds of reasons, the phone has become essential and an essential part of people's lives. And incorporating that into self-management is just a great opportunity to advance support for behavior change.
Great. So John, what are some of the most successful fully digital programs that you've seen?
I try to think of digital programs in terms of what the function is that they're serving. So let's take a simple example. One very simple, straightforward example is reminder systems. So most of us lead very chaotic lives. Again, people that have economic challenges or other vulnerabilities, people that are older, life seems very disorganized and complicated. So simply those reach outs to remind people to do things are incredibly effective. And there are huge meta-analyses that have shown that again and again. So we might remind people to show up for their vaccine. We might remind them to show up for a follow-up visit. We might remind them to take their medications as prescribed. Simple reminder systems by text messages have been shown again and again in large trials to be effective. So that's one example. Another basic function that we can have with mobile health is monitoring. So when we have a big population of people, one thing a live telehealth program has difficulty doing is knowing how to direct those resources to the subset of people that really need the help right now. And we can use text messaging systems, IVR or automated calls, or other apps to monitor populations, identify people into triage groups, and select people that really need assistance, understanding what they should do, making those behavior changes, or dealing with a health complication. Right now, we're in the process of doing just that in the topic of COVID for people in Latin America. And we're excited about that because resources are so scarce in those call centers with human resources that adding on an automated component on the front end is really a great thing. The last area, let me just say really quickly, is actually helping people make behavior changes. And I'll just throw out one simple example was that really made a big difference to me was the Text to Stop program from the UK, which used simple texting and a series of follow-ups to help people who are interested in quitting smoking be successful. Frankly, I didn't personally think texting would be successful in that very difficult behavior change. But you know what? They doubled cessation rates. And so simple things like that that have massive applicability and really low cost at the population level are something we all should be pursuing.
That's interesting. That particular program was one that we studied. One of the first programs we put together at Observia was smoking cessation, and Text to Stop was a real inspiration for us.
Yeah, that's really great. And people that are making often socially undesirable, they are struggling with socially undesirable behaviors like smoking, substance abuse, alcohol, drug abuse. They're actually often the people that are most reliable in responding to automated modes of communication, and the information they report is really quite good, quite valid.
Last question for you. What are the key success factors for a digital program? For a lot of the people who are watching this video are interested in putting together programs and probably have put together programs, but not necessarily digital ones. And we know for all the success we've seen that many fail. Or at least less successful than would have been hoped. So what are in your experience, some of the key success factors?
You know, I think the number one thing, Kevin, and this is a high bar, this is a challenging problem for us that work in mobile health, but the idea is that we need to communicate with people in a way that they endorse as an end user as something that's important to them. You know, this is a kind of a perennial challenge to us that people stop using our mobile health tools. But you know what? In other areas of mobile phone use or social media, the challenge is how do we get people off of these things, right? They're using it so much. So there's something that often we're not doing right in terms of mobile health, that people don't endorse it as something that's valuable to them or don't understand what the impact and values to them. So I would say that that's the number one thing. The next thing I guess I would add is to really be communicating with people in a modality that they're comfortable with and familiar with. There are some really exciting opportunities in apps and some examples where apps have been very successful. But many people, it turns out from research, aren't really interested in downloading an additional app, logging into their diabetes app. So that's why with some of our programs, we pursued things like WhatsApp, text messages, simple IVR calls to reach people through communication channels that they're already using without really requiring them to do more. And then I guess the last thing I'll say is, everybody likes a good theory. We know a lot about behavior change. We actually really, really do. One of the main things we know from self-determination theory, which is a big driver of a lot of our interventions, is that people don't like being told what they should do. They need to feel like we're supporting their autonomy to make the behavior changes that are important to them. And that's tough to do with mobile health. It's really easy to say, Kevin, don't forget, you need to take your medication today. But people often are resistant to that, and that might be one of the main reasons they stop using them. So we need to really talk to people that understand health psychology and these behavior theories so that we can develop interventions that are user-friendly and seen as being supportive instead of overly directive.
Absolutely. I actually, John, I have one more question for you. Was there some kind of, and I'm asking the same question to all the people that are joining us in these interviews, what drove you into the area of patient support? I mean, you know, you're a well-established academic, you've studied behavior, you studied all this, but is there something fundamentally, you know, for you that said, wow, this, I really want to focus on?
That's a really great story, Kevin. I'll try to not make it be too long, but when I cut my teeth, when I got my PhD 1,000 years ago, that actually was back in the 80s, early 90s, and we were just in the beginnings of the HIV/AIDS epidemic. At that time, we didn't have good antiretroviral therapies. The treatments for the opportunistic diseases and infections were also poor. So the life expectancy for a more advantaged person was maybe 9 months to a year post-diagnosis. I mean, people were dying. You know, it was a terminal illness almost at the point of diagnosis. But what we saw at that time that had such an impact on my entire career is that we saw huge variations in that life expectancy between, for example, more advantaged white gay men in San Francisco, you know, in my country, the United States, and maybe like an IV drug using woman from an ethnic or racial minority community. Maybe the white gay man might be living twice as long. So the message I got from that was, if we can just get her what he's got, we can have an enormous impact on life expectancy, even though we don't understand how this disease works. We don't have any good treatments. All we have to do is figure out how to do better self-management and support behavior change with this group, and we can make such an important difference. That was my example from early on in the AIDS epidemic, and that same example can be told again and again if we're talking about diabetes, hypertension, obesity management, or now with preventing and managing symptoms of COVID-19.
Absolutely, and that's a really, really interesting and telling example. And of course, I remember as well. But, thank you very much, John.
It's a pleasure.
That's it. You've had some really interesting things to say, as you always do, and I'm sure that everybody who's watching the video is going to be able to learn from your experience. So thanks.
Great.